Okay, thank you to the course organizers. Welcome the opportunity to talk a little bit about the Venovo stent from BD. These are my disclosures. The only thing relevant is that I do work on some clinical trials with BD, but nothing related to this particular device. So as we've heard a lot about venous intervention, the field has changed significantly over the last several years, and now we're developing stents specifically for the venous system, so maybe with a different radial strength profile compared to the arterial system. So the Venovo stent is a very purpose-built, self-expanding, open-cell nitinol stent. It has flares on both ends, 3 millimeter flares, so it's a little bit larger at each end with tantalum markers so that you can see it well under fluoroscopy. Comes up to 20 millimeter diameters and up to 160 millimeter lengths, and is mounted or is placed in a triaxial delivery system. There's a dual speed thumb wheel deployment, so you can either deploy it initially, just like Aaron was doing with a different type of stent, very carefully for the first centimeter or so. Once that is started, been deployed, you can use the fast thumb wheel and deploy it quicker. And its indications for use are in the iliofemoral venous outflow segment for outflow obstruction. The VERNACULAR study was the clinical trial that was used to get its IDE approval. It was a prospective, multi-center randomized study looking at the performance of the Venovo stent in patients with symptomatic iliofemoral venous occlusion. And patients had to have at least a SEEP3 score or a pain component of the venous clinical severity score greater than 2. There was exclusion if you had involvement of the IVC, so patients with chronic IVC occlusion or IVC atresia were excluded, or if there was significant disease below the lesser trochanter, if they had a previous stent, or if there was a not appropriate size for the iliac and femoral vein. The lesion characteristics within the study that led to its approval showed about a 76% stenosis pre-procedurally. Mean lesion length was just under 7 centimeters. About 95% of these patients had common iliac vein involvement, or the stent was placed in 94.5% of common iliac vein, about 40% or so within the left external iliac, or within the external iliac vein, and about 9% in the common femoral vein. The vast majority of these patients were treated with a single stent, fortunately, based on the size matrix, and then post-intervention mean stenosis of about 14%. The safety endpoint for the VERNACULAR study looked at freedom from major adverse events at 30 days, kind of a typical endpoint for device studies, looking at target vessel revascularization, either device or procedure-related thrombosis, amputation, symptomatic PE, some type of vascular injury that required any kind of intervention, and of course device migration is important as well as death. They compared the outcomes of the Venovo study to an objective performance goal, which was set at 89%. This is basically looking at multiple studies of how venous devices performed over time, and there was a statistically significant improvement using the Venovo device at 93.5%. The effectiveness endpoint was a composite. It was primary patency as viewed as a composite of freedom from target lesion revascularization, thrombotic occlusion, or duplex ultrasound of greater than 50% stenosis. Again, compared to an objective performance goal of 74%. And it was about 88.6% with the Venovo study. If you split this into two cohorts with the post-thrombotic population versus the NIVL population, a significant difference there as well. 81.3%, as you'd expect, a little bit less, lesser performance in the post-thrombotic patients versus the non-occlusive iliac vein lesion. Secondary endpoints included technical success, which was 100%. Then they looked at some patient-reported outcomes using the Civic 20 study, which is basically gives you a global index looking at 4 parameters. It includes pain level, physical performance, psychological, social things. So the lower the number, the better the patients were doing, and they saw an improvement of about 15.7 on the 20-point scale from baseline. The pain component of venous clinical severity score was also improved significantly, and importantly, no stent fractures at 12 months. And then at 3 years, this data was reevaluated. So 128 patients of the initial entire study population completed 3-year follow-up, and they noted a freedom from TLR or TVR at 3 years of about 88%. If you look at this as a Kaplan-Meier estimate, where you are excluding the patients that were censored from loss to follow-up, you still have an 84% overall primary patency. And again, even at 3 years, no stent fracture and no stent migration. These are the 3 years results, as I talked about before. Looking out now at 3 years, the venous clinical severity pain component, again, improved by 1.8. And then the Civic 20 score, again, the lower the number, the better in terms of patient comfort. And in addition to this improvement, the SEEP classification improved by at least almost 1.5 stages. Here's a quick case showing use of the Venovo stent. This is a 68-year-old with chronic lower extremity edema, pigmentation, lower extremity heaviness, classic symptoms of venous claudication. And you can see there's a chronic total occlusion of the IVC, common iliac veins, extensive pelvic collaterals. This is working our way through, recanalizing the occluded segments, wire access from both sides. After balloon angioplasty and then IVUS evaluation to determine the proximal end of the stent, and then some balloon angioplasty. Use a technique here before with the occlusion extending into the IVC, what we talked about, kind of an inverted Y configuration, and delivering a 20-millimeter stent with 14-millimeter stents inside. And here's the completion venogram showing, again, excellent brisk flow through the previously occluded iliac veins and through the IVC. Just for completeness, this device was removed from the market a little over a year ago for some issues related to what they call the stent cushion on the back end of the delivery system. Not related to the stent itself, it's all related to the delivery system, and this issue was ultimately rectified and it's been back on the market, I believe, for about 4 or 5 months now. So it was off the market temporarily, fixed this delivery system, and now it's back in action. So in summary, the BD Venovo stent is one of the earlier dedicated open cell venous stents, FDA approved for iliac intervention and venous outflow disease. A broad size matrix enables you to treat the IVC as well as the iliac veins and femoral veins. It's supported by the longest published data in terms of iliac venous intervention and specifically for iliac vein stents at 3-year follow-up with a pretty impressive 84% primary patency out to 3 years. We've talked a lot about how we maintain stent patency in this population, so those are pretty impressive numbers. And perhaps more importantly is that the patient-reported outcome measures when it comes to quality of life and decreasing pain shows very favorable results. Thank you very much.